Hi, I'm Mr Shyamalan, consultant hand surgeon, and this is a patient educational video on base of thumb arthritis.
Hi Mr Shyamalan, could you talk me through what I could expect if I had a consultation with you?
Of course. Usually patients are referred because they're struggling to open tight jars or they have pain in their thumb and it's interfering with the activities of daily living. We tend to offer any treatment to patients who have problems with pain and obviously problems with function. So, and I would say, looking at the history of a patient, they would say over time the thumb has become more and more painful, perhaps to a point now where it's painful all the time. And one makes the assumption they've tried simple painkillers such as paracetamol and it's still struggling a little bit. And then you have those functional problems where, as I mentioned, just gripping tight objects and lifting and carrying and day-to-day tasks become uncomfortable. Worst case, it starts to wake you up at night because you have pain. On the examination aspect of it, we look to see how the thumb moves, really. So if you put up your hand for me, the thumb is quite unique. It has quite a wide range of movement. Come up to the top here. So this is abduction, and then as you come to the little finger, that's called opposition. And certainly with thumb arthritis, coming over to the thumb sometimes is quite painful over the base here. Now the thumb can have pain in lots of spaces, so we do look at all its movements, bring the thumb backwards, that's called retropulsion, and the thumb towards the finger here, and all the way nice and wide. And we look for any swelling and discomfort or any other signs of arthritis. So a lot of patients who have arthritis in the thumb have arthritis in other joints as well.
Thank you. And after the consult, would I need any other investigative work done?
Based on where you're pointing to your pain, simple x-rays is a really good start to advise if someone has an obvious arthritis. If the picture isn't as clear, or perhaps if the x-rays are normal, we can certainly look through modalities like ultrasound or MRI scanning. But as a general rule, I would say a simple x-ray is a sensible option. Then we can start to actually decide whether that's the main reason for the problem that you're having.
And after the x-ray and the consult, what would be my treatment options?
With any arthritis, and this is like a global term of arthritis, it waxes and wanes. Sometimes it's better in the summer months, worse in winter, it's worse after use, and patients, as I say, mostly don't come to a doctor if the levels of pain are within kind of 5, 6 out of 10. It's only when it becomes 8, 9 out of 10 and more prolonged. So once again, simple painkillers, avoidance of certain activities. So two key terms are activity modification and joint protection. Activity modification is basically not doing the things that hurt. So if those jars are really tight, work out different ways to open them that aren't related to you straining the thumb or pulling heavy doors. And likewise, joint protection, there are certain, although they're not hugely evidence-based, having fish oils and glucosamine, and basically the body's natural anti-inflammatories sometimes can help with pain. Stronger painkillers such as ibuprofen, which is a non-steroidal anti-inflammatory drug, can help. And then we move up to more interventional things like steroid injections. Steroid injections, once again, are in our armament of pain relief, as is in fact surgery. It's all geared around helping with pain.
And could you talk me through the surgical route? Sure.
So having diagnosed you with specifically base of thumb arthritis, one of the more common procedures that we do is trapezoectomy. Now at the base of the thumb there's a small bone called the trapezium. So removing that bone, interestingly, for those patients who have severe pain and severe functional problems, the outcome is very good actually from improving pain. Yes, it's not a normal thumb at the end of it, and there is some weakness related to removing that bone. However, if the pain is so significant that you're not really using the thumb, I would say still it has a good outcome. But that's once again making the assumption that you've seen a physio, perhaps you've tried splints, you've had injections, and you're really prepared to have that procedure because those other things have just not worked and the pain has progressed. Now, with having a trapezium, we remove the bone. Occasionally, to stop the thumb dropping back into the gap where you remove the bone, you suspend the thumb, either using a tendon or some kind of device. And sometimes we put a little spacer inside the gap that we cause. Now, that's not to say there aren't other things we can do. Now, keyhole surgery, where we shave the 2-3 millimeters off the top of that trapezium, and that leaves a gap as well that forms hematoma and eventually scar tissue, is one form of treatment, as well as joint replacement. So joint replacement, where you basically, much like a mini hip replacement, you put a ball in a socket, and that functions reasonably well. I would say actually from a functional return, the joint replacement works very well, and obviously good for pain relief. So like any procedure, it has to be discussed with the patient of which one you would think is appropriate for you.
Thank you. And could you talk me through the recovery?
Sure. So once again, it's about getting that pain settled first. So once the wound is healed, and that takes about 2 weeks to get the dressings and to change from the cast that I put on surgery, at about a week or two I change it to a plastic splint. So whether it's joint replacement, whether it's trapeziectomy or any keyhole procedure, I normally put a small lightweight cast for a week, check the wound, and then we put a plastic splint, which is removable, so good for hand hygiene. Yes, you probably shouldn't be doing any lifting, carrying, getting the wound wet for a couple of weeks, but simple tasks. We expect you to move your finger straight away, glide the thumb straight away, move the wrist straight away. And then we start bringing in those other movements in the thumb over the next few weeks and start some simple lightweights by 4 weeks, with a view to returning back to most activities by 6 to 8 weeks. And by 3 months, you should be heavy lifting and doing the things you like doing. With either of those operative plans, we tailor it to how the patient is doing. Mm-hmm. So some do very well rehabilitation-wise, others are a bit slower, and we have to give them a bit more time.
And would there be a need for physiotherapy along the route as well?
Absolutely. From the outset, when they make the splints, to massage, bringing down the swelling, stopping the stiffness in the fingers and the wrist, it's an integral part of the surgery is to have the post-operative physiotherapy as well.
And could you talk me through, will there be any complications to any of these operative routes? Absolutely.
So I guess let's talk about trapeziectomy first, because that's the most common one. So I think the main thing that people notice in trapeziectomy is that the thumb feels a bit weaker. Now, as I said, generally it's weak before because it's so much in so much pain, but that can be quite noticeable for certain people with their grip strength in comparison to the other side. Obviously, wound infection, general complications that tend to be small but treatable early, and then stiffness in the hand and the thumb and getting that functional return. Failure of the procedure, which means basically the pain is still there, or the pain comes back after the period of time, could be due to a myriad of reasons, but it may just because the thumb has collapsed back down to the gap that you've created, and that just ongoingly gives them discomfort. Obviously, like any procedure, there's another thing one can do, but I would say it's one of those 9 out of 10 procedures, and most people do quite well after a period of time, and those who are still struggling, there's always something else one can do. So it wouldn't be the go-to procedure for early arthritis, and one would try to manage it in lots of other ways, but as I say, it's a tried and tested procedure for many. Now, joint replacement has, when it first started, had a pretty bad reputation because it wasn't as long lasting as a hip replacement, and so they can dislocate, they can get infected, the implant can break. But the newer types of implants are certainly lasting a lot better. So I'd say for the right patient, it is a good procedure, and perhaps if you are a heavy manual worker and you use a hammer a lot, maybe it's going to wear out a little bit quicker if you do less activity and less gripping and lifting. So it's certainly something I discuss with patients before advising. And keyhole surgery, once again, you're still resurfacing the joint, you're still taking away the surface of the joint, but it's just more minimally invasive. So you're not opening up the whole capsule, the baggy sheet around the joint. In that type of procedure, sometimes those little nerves that supply the sensation in the thumb can be affected. But I think for most patients, what they really want to know is, can I return back to all my activities, and will I get ongoing pain? And so, as I said, even for those other groups, whether it's a complication related to the joint replacement or to the keyhole surgery, it's persistent pain, really.
Thank you.
You're welcome.